second case is about a large chronic pericardial effusion, and the question is to tap or not to tap the effusion. It is a 69-year-old female patient with the previous diagnosis of rheumatoid arthritis and Sjogren's syndrome that was referred to us for a second opinion. She has a known large chronic idiopathic pericardial effusion since 2010, and in March 2011 and in September 2011 she underwent 2 diagnostic pericardiocentesis without pericardial drainage. The pericardial effusion was analyzed and always reappeared after a few days, and she also attempted an empiric anti-inflammatory therapy with non-steroidal anti-inflammatory drugs and colchicine without significant changes of the sites of the effusion. The etiological testing on pericardial fluid and also on this patient was negative, and the final diagnosis was a large idiopathic pericardial effusion. She was always asymptomatic, and the pericardial effusion was detected incidentally following a chest X-ray and a subsequent transthoracic echocardiogram. This is the electrocardiogram of this patient showing low QRS voltages and also electrical alternance. As you can see, a variation, a change in the size of the air wave from beat to beat. And also we can see a large pericardial effusion defined as a semi-quantitative assessment of more than 20 millimeters as telediastolic echo free space that you can see here and here. And also without significant changes of mitral E velocities on Doppler echocardiography, and also maintaining changes of inferior vena cava sites with respiration that you can see here. So no evidence of cardiac tamponade in this patient despite a large pericardial effusion. So my question number 1 is, what is your next diagnostic step in this patient? So first option, pericardiocentesis again. Second option, pericardiocentesis with pericardial drainage. Third, pericardial biopsy. 4, repeat full etiological investigation. And last one, no additional need for etiological investigation if already performed and the patient is asymptomatic with a stable chronic large effusion.
Okay, so again, 1 minute to answer. And meanwhile, I want to ask you, Massimo, a question from the audience. May sport provoke recurrences?
Well, I don't think that sport may be the cause of recurrences. However, it is important if a patient is has a pericardial inflammation in the acute attack, either acute pericarditis or recurrent pericarditis, exercise restriction is important, because if you have an inflamed pericardium, physical activity with tachycardia is not helpful if you have to overcome the pericardial inflammation. So I think that exercise restriction is an important component of our therapy, is a non-pharmacological component of our therapy. But if the patient has a remission, there are no contraindication to perform sports.
Okay, and we have the answers. So there are 5 multiple. The first is 5%, the second is 30%, 25% to the third answer, 15 to the fourth, and 28 to the fifth. So we have 3 leading results, 2, 3, and 5. Yes. What do you think, Massimo?
Yeah, really in this case we don't have the right answer, but according to the patient also will and also the specific condition, we consider different aspects. I think that pericardiocentesis was already performed twice, so in this patient. So if we really have to perform another pericardiocentesis, we probably have to consider also pericardial drainage. And this was proposed to the patient, but the patient rejected because it was the third time for her. Regarding pericardial biopsy, we don't have enough evidence that probably this diagnostic test can be helpful in this patient. It is an option if you are in a skilled center and if the patient accepts this option, but the patient didn't accept this option. I don't think we need to repeat a full etiological investigation if we are confident that the previous evaluation was good. So another option that is the last one, so no need for additional etiological investigation. If you feel that everything was done very well, there is no new data that suggests us to perform additional testing. And also considering that the important aspect that the patient was asymptomatic, and also her will, because the patient didn't want to perform additional intervention, and so this is a question to be considered. The next question is, do we have to recommend a specific treatment for this patient? So the first option is yes, and we suggest aspirin or a non-steroidal anti-inflammatory drug plus colchicine. The second option is colchicine alone. Third option, corticosteroids plus colchicine, pericardial window or pericardiectomy.
And again, 1 minute for answer. And George, meanwhile, I want to ask you about the procedures, pericardiosynthesis, puncture. A lot of doctors are afraid to do it, even in the most sophisticated hospital. What do you want to tell them?
Pericardiosynthesis is an invasive procedure by definition. So when you proceed in doing an invasive procedure to a patient, you should be covered in case of something happens. So I don't think pericardiosynthesis should happen in the middle of nowhere, unless it's to save somebody's life. It should be part of a dictated and calculated thought process, and should be done by experts in the field. Pericardial window, the alternative to pericardiosynthesis with probably a more consistent drainage. It can be done as a day case with VATS, so it doesn't really need major surgical intervention, and it should give a better kind of relief. Pericardiectomy is it's a bigger thing. It's a bigger operation, and it deserves a lot of thinking before you actually jump into that.
Thank you, George. Massimo, the answers. Majority to number 1, aspirin or non-steroidal plus colchicine, 35%. 11% to colchicine alone. 18% to corticosteroids plus colchicine. 25% to window, pericardial window, and 12% to pericardiectomy. So most of the answers go to number 1 and number 4.
Okay. So, well, this patient was symptomatic with no evidence of pericarditis. So she already tried empiric anti-inflammatory therapy. So there is no evidence that empiric anti-inflammatory therapy can be helpful in patients with an isolated pericardial effusion without pericarditis. So this is the first step. We don't have any evidence that colchicine alone is good, so it's a good option. Colchicine generally should be considered on top of standard anti-inflammatory therapy. We can consider probably pericardiosynthesis with pericardial drainage because it was not performed before, or even pericardial window. We also presented to the patient all the possible options, but she was asymptomatic. She was very afraid. So after 2 pericardiosynthesis, she wanted to stay on medical therapy and to wait. So we decided to wait and see what happened to this patient, because also we know that for large chronic pericardial effusion, what is large? Large is defined by the guidelines are more than 20 millimeters of telediastolic echo-free space, and is defined chronic by expert opinion when lasting for more than 4 months. So this patient has a large and chronic pericardial effusion. It is labeled idiopathic when the etiological evaluation is negative, as in this case, even after the analysis of pericardial fluids. And the analysis of pericardial fluid was done twice in this specific patient. In a symptomatic patient that is a big problem, such as this patient, the finding may be incidental, and the outcome is poorly known. This is the classification provided by the guidelines. Pericardial effusion is considered according to onset, sites, distribution, and composition. And you can see that we recommend, as in the guidelines, a semi-quantitative assessment of the sites of diffusion. It's very simple. It can be performed even in the emergency department at bedside, simply considering the largest telediastolic echo-free space, considering different echocardiographic use, as here. And this is the etiological diagnosis for moderate to large pericardial effusion. What are the causes? So cancer is an important cause to be considered. Infection, especially tuberculosis, and you can see that in series coming from developing countries where tuberculosis is highly prevalent, infections are very important. So tuberculosis should be ruled out. Connective tissue diseases are an important cause to be considered, but also metabolic causes, especially hypothyroidism, and iatrogenic may be emerging in our setting, especially related to interventional cardiology. So these are the main causes that should be considered when we are evaluating a patient with a pericardial effusion, especially if moderate to large. And also we have to consider the speed of accumulation of pericardial fluid. So if you have a large effusion, this means that the pericardial effusion was slowly accumulating. So we have evidence that the pericardial is rather stiff. So if the increase of the size of the pericardial fluid is low, as shown in this slide, the limit of pericardial stretch is reached for high pericardial volume. So this means large chronic pericardial effusion as for our patient. On the contrary, if the accumulation is rather quick, as in hemopericardium, the limit of pericardial stretch is reached very soon for small volumes, and this is a typical case of a cardiac tamponade following hemopericardium. The natural history of large chronic pericardial effusion is poorly understood. We have only, the major study is a study of 28 cases. At the beginning, about 50% of these cases were completely asymptomatic. After a mean follow-up of 7 years, about 1/3 developed cardiac tamponade, and especially because of a triggering event, such as pericarditis or chest trauma. And at the end of the follow-up of all the patients, 86 patients underwent pericardiocentesis, and 71 were submitted to pericardiectomy, because this was the policies of the study group. So this is what we know. This is the only study. So what is the progression of the patient was completely asymptomatic. Her will was to wait, not to perform additional testing and additional interventional procedures. And also we had no physical and echocardiographic sign of cardiac tamponade. So we decided to wait and monitor the effusion within 3 months. After 3 months, the effusion was unchanged, and so we decided, however, to perform another pericentesis, but with a prolonged pericardial drainage. We persuaded the patient to do at least to try to perform a prolonged pericardial drainage, because it is showing also in the literature that is an option to be considered. And we checked again the pericardial fluid to be really sure that that there was no specific causes to treat in this patient. And also we wanted to test the possible efficacy of a prolonged pericardial drainage. And however, you can see the evolution of the pericardial effusion in this patient. Completely asymptomatic at the beginning, we performed the pericardioccentesis with drainage, and you can see the reduction of the size of the effusion. Here you can see the telediastolic echo free space from 25 to 50. But again, after a few months, the size of the effusion increased again to the baseline level. So the pericardioccentesis, even with drainage, was not successful. And here you can see a triggering event. So pericarditis, this pericarditis was treated with an increase of the size of the effusion. After a good treatment of pericarditis, the patient became asymptomatic, C-reactive protein were normalized, the patient is asymptomatic, but you can see the size of the effusion is now increased. So this is a...
And I want to disturb you with a very interesting question. And the question is, what about giving diuretics to those kind of patients?
Well, diuretics are not a good treatment for this patient, because we know that they can only reduce the effective circulating volume, and so they can precipitate cardiac tamponade in patients with large effusion. So it is not the treatment that should be offered. And in the guidelines also we remark it very well that they are contraindicated, especially in the patient with the cardiac tamponade, and in the setting also large effusion, I think they are contraindicated.
Okay.
About the role of medical therapy, we don't have evidence that in the absence of inflammation, as in this patient at the beginning, anti-inflammatory therapy are worthy, should be considered. And also in the guidelines, we reported that probably additional testing should be considered. So before performing this test, we performed the computed tomography in this patient. Second-level imaging test should be considered in this patient, especially if we have loculated pericardial effusion, pericardial thickening or masses, and also associated chest abnormalities. This is well reported in the guidelines. And also admission is not recommended unless we have high-risk features that we show you later. And moreover, we recommend a sort of triage of this patient, and this is the triage. If you have cardiac tamponade or a suspicion of bacterial of neoplastic etiology, pericardiocentesis is clearly recommended, because the definitive demonstration of the etiology remains the demonstration of etiological end agents in pericardial fluid. Otherwise, we have to exclude pericarditis. If you have elevation of marker of inflammation of diagnostic criteria for pericarditis, the treatment of the effusion is the treatment of pericarditis. Otherwise, it is important to consider if there are known associated diseases, because we know that from the literature that in about 60% of these cases, there is an underlying disease, such as a connective tissue disease. And in that case, the treatment of the effusion is the treatment of the underlying disease. If not, as in the case of in this patient, we had the connective tissue disease. The patient had a diagnosis of rheumatoid arthritis, but the size of this effusion is not explained by the presence of rheumatoid arthritis. And so if large, and it's in this patient, considering the possibility of triggering events such as pericarditis or chest trauma, we have to consider pericardiocentesis, especially if the effusion is chronic, to prevent the risk of for the patient of developing cardiac tamponade during follow-up. Otherwise, we have to consider follow-up, also considering the patient preferences. And this is...
Before this, I want to ask you, George, the question is, It is possible to perform partial pericardial resection?
Of course, everything is possible in life.
Especially in Oxford.
But it's not. I don't think it's appropriate. When you go in, you should perform what we call a complete pericardiectomy, from phrenic to phrenic, free the inferior vena cava or the vessels, perform pericardiectomy on the diaphragmatic sides of the heart, free the heart up. Is that feasible to all the cases? Sometimes not. You may end up going into theater. Probably every surgeon has one of those cases where you go in, has the best intentions, and you can't do anything because everything's so stuck. Or other occasions where you have calcium because of TB that's growing in the muscle, so you leave some pericardium behind. I think the ultimate goal is to actually do a complete pericardiectomy, and you should aim to do that at all occasions.
Thank you. Okay, Massimo.
These are the guidelines recommendations, so try to target the therapy as much as possible at the etiology. Consider anti-inflammatory therapy, especially if we have evidence of systemic inflammation and pericarditis, and consider pericardiocentesis, cardiac surgery, especially if you have cardiac tamponade or symptomatic moderate to large pericardial effusion, not responsive to medical therapy, and especially, as remarked before, if you have a suspicion of bacterial or neoplastic etiology.
Okay, we'll go to question 3.
Okay.
How would you plan the follow-up? First answer is no additional follow-up is required unless symptoms develop. Number 2, plan an echo every 3 months. Number 3, an echo every 6 months. And plan an echo every 12 months. You have 1 minute to answer. And there are a lot of questions. I'm sorry I can't ask all the questions. There are, I think, thousands of questions here. But one of the questions here, what about intrapericardial drug injection during pericardiocentesis?
Well, this is a possible option. We had studies in the past from the Marburg Center suggesting the use of intrapericardial triamcinolone and corticosteroids to prevent the reaccumulation of pericardial fluid, especially in autoreactive pericardial effusions. We have indication to perform also antineoplastic therapy for specific kind of cancer in the setting, in the specific setting of neoplastic pericardial effusion. So it is a valuable option, but for specific patients.
Okay, George, you wanted to add something?
No, I think Massimo addressed that the issue of installation. I think most of this data is just a little bit dated nowadays, and I'll keep that at the very back of my mind, really, as a treatment option.
All of us.
Yes.
Massimo, the answers, so majority to number 2, an echo every 3 months. After this, we have 24% for 3. We have 70% for 2, so...
Okay, I agree with the colleagues, and also in the guidelines we tried also.
I have to give compliment to the audience. They read at least part of the guidelines.
Yes, yes. We tried to provide some recommendation in the guidelines based on, obviously, on our expert opinion. For mild diffusion, no need for echo follow-up. For moderate, consider echo every 6 months. For large diffusion, every 3 to 6 months, especially depending on the symptoms of the patients, on the also the evolution of the size of the pericardial effusion.
And of course, if the patient has on top a pericarditis or something like this, immediately to do an echo to see if he's not developing tamponade.
If there are triggering events such as a chest trauma or pericarditis, you have to reconsider again the case and to perform echocardiography for this patient.
Immediately, yeah.
So in my view, the key messages of this case are that this case shows that a chronic large pericardial effusion may be asymptomatic and stable even for a long period of time. Precipitating events such as pericarditis or chest trauma may be responsible for worsening and should be considered in the decision to treat. Careful echocardiographic follow-up is warranted for this patient every 3 to 6 months, depending on the symptoms, the pericardial effusion site changes, and the management should be tailored to the single patient according to his or her preferences and evolution. Pericardiectomy is generally the last option to be carefully considered and offered in well-experienced surgical centers, since it is a long and demanding cardiac surgery surgery operation. And last, we have to consider also the role of pericardial window that can be probably considered even before pericardiectomy. It is often an alternative option to be considered and offered to our patients.
Thank you very much. I think it's a wonderful two cases who cover a lot of the data from the guidelines. I want to speak with you, George, about post-pericardotomy syndrome. And we have a question here. Postoperative pericarditis, is colchicine an option instead of steroid or non-steroidal anti-inflammatory drugs?
I think probably if you look to the data, it's the only option. We have data from Italy and from Israel that say that colchicine is reducing the incidence. So by definition, I think that's the only option we have.
I want to add the data George is talking now. It's about two trials, one made in Israel 10 years ago, and after in Italy in 6 centers we did it. And we showed that when you give colchicine the third day after open heart surgery for 1 month, it decreased the incidence of PPS in 50%, from 20% to 10%. By the way, the results are amazing, the same in 2 centers. Mm-hmm. So,
yeah, the only problem we have is penetration of that information into cardiac surgery, everyday cardiac surgical practice. And it's up to us to disseminate the information and improve that penetration.
What do you think, Massimo?
Yes, I agree. And there is also a problem of having the correct dosages, probably considering to avoid loading doses and to consider weight-adjusted doses. For patients of less than 70 kilograms, probably 0.5 milligram once daily is enough, and we don't need to have higher doses to improve patient compliance.
Okay, I have another very interesting question. What are the signs of pericardial inflammation by CT?
Yes, it is an important question because on CT, the inflamed pericardium can show contrast enhancement. However, if available, I think the best imaging technique to depict pericardial inflammation is cardiac magnetic resonance, because I showed in the case before, you have a combination of pericardial thickening, pericardial edema, and pericardial late gadolinium enhancement, and you can even be able to differentiate acute from chronic phases, because acute means pericardial thickening plus pericardial edema plus late gadolinium enhancement, and in the chronic phase with fibrosis you have only late gadolinium enhancement and maybe pericardial thickening sometimes. So it's very helpful.
And another question on imaging. Can MRI differentiate acute from chronic pericardial disease?
Yes, I pointed out if you have an acute form, if you have acute inflammation, you should have pericardial edema. So on T2-weighted imaging you will have evidence of pericardial edema. If you have only evidence of fibrosis, you will have late gadolinium enhancement, but without pericardial edema. This is my experience.
Yes, and another one, how I have to treat TB pericarditis.
Yes, this is
very well in our area, but not in South Africa.
Yes, but it can be an emerging form of pericardial disease because of immigration, and the treatment of TB pericarditis is based on antibiotic therapy. So I think that in this case we should have a multidisciplinary approach, including consultation with an expert in infectious diseases, and cooperation with him is very important. We know that with the prompt and effective treatment we can prevent very serious complications, especially the evolution towards constrictive pericarditis.
I think we can go to the conclusion, and we are now approaching the end of the webinar. I hope we have enlightened you and broadened your horizons with the provision of new information. Nonetheless, there is still a lot of work ahead of us, and therefore it is still the main element that need to be accomplished in the coming decade, up to the next ESC guidelines. However, would like to join us is most welcome, and indeed the remaining question is what next? And we'll speak now about what next. We'll speak about epidemiological data. We speak about acute pericarditis, management of recurrent pericarditis, pericardial effusion, PPS, and neoplastic disease. This is only part of what next. We have a lot of work to do. We did amazing work in the last 30 years since we started to work with David Spodek and Raf Shabtai, and later with Bernard Mesh and Baez de Luna. And let's speak about epidemiological data. What next? There is a need to gather much more specific epidemiological data from different geographical areas and possibly from each country separately. I have the impression, and Massimo, you will agree with me, that even with colchicine, the reaction of the disease, acute and recurrent pericarditis to colchicine in the Mediterranean, it's much better than, let's say, in South America or North America or Africa. We have to check it. Maybe we're talking about different etiologies. Test data are highly important for diagnosis of different etiology related to various areas and countries around the globes, and may provide an explanation in the difference in treatment between those different areas. In light of this, a dedicated team is wanted that would be established by the ESC to examine and analyze this issue. This is a very, very important issue, and you agree with me. Mm-hmm. George, you agree with me. The other is for acute pericarditis. Regarding etiology, again, the question remains regarding the idiopathic issue. What is idiopathic? Is it viral? Is it something else? And again, we need the ESC to examine this issue by a dedicated team for this issue too. Management of recurrent pericarditis, what next? You spoke about it, Massimo. The greatest challenge is with patients who have not responded to conventional treatment, including non-steroidal and anti-inflammatory drugs, corticosteroids, and colchicine. Recently, they are promoting data, and I have several questions about it from the audience regarding the effectiveness of anakinra. But we need a prospective double-blind research to discern the effectiveness of IVIG, azathioprine, and anakinra, and maybe to compare it, George, to pericardiectomy, because maybe pericardiectomy is much safer than a conservative treatment, although we are conservative and you are a surgeon, but we have to check this point too. Pericardial effusion, we spoke about it. We do not have enough data regarding the recommended approach to chronic moderate pericardial effusion. Should be conservative, like Spotik wrote in his book 20 years ago. Should we do pericardial synthesis like mesh claims, maybe other treatment? So we need to do research in this field too. Post-cardiac injury syndrome. George, you spoke about the 2 trials in Israel and Italy for colchicine after open heart surgery and decrease the PPS incidence, but we need a larger trial. We need to do once forever a multi-center large trial, prospective double-blind, and to check this effectiveness of colchicine. I have no doubt this is the best. You know, a lot of centers even today give steroids after open heart surgery, and they cause a lot of damage to the patient. They don't agree with us. We have to prove it to the next guidelines and to put it as number 1 recommendation. Neoplastic disease. Very interestingly, 5 common malignancies like to go to the pericardium. We are talking about melanoma, lymphoma, leukemia, breast cancer, and lung cancer. So some people tell me, listen, the lung and the breast are very close to the pericardium, so they are going to the pericardium. So what about esophagus? Did somebody saw esophageal cancer with metastasis to pericardium? What about prostate cancer? So maybe there is an anti-inflammatory material secretion for the pericardium or the myocard to some malignancy. We have to check this point. This is a very important point and very interesting one. And here we can see the TF members who worked for 2 years with Philip Sharon and with you, Massimo. And we did, I think, an amazing work. The new guidelines of 2015 are super guidelines to give answers to all the issues of pericardial disease with algorithm how to treat the patient and how to go to the patient, even not for cardiologists, for internal medicine, for family medicine. And I think I have to thank all the TF and you for wonderful work. We now close the webinar. Thank you, Professor Massimo Imazio, for your noteworthy presentation, and Dr. Kaspoulos for joining us today with your experience in the field. We hope you enjoyed this time with us. You will be able to view again this webinar offline in a few days on the ESC website. Thank you very much. I enjoy very much.
Thank you.
And we'll continue to work on pericardial disease. Thank you.
Thank you.
Thank you.